Great. I can jump in. Thanks so much for having us. It's really great to see this group, and I can sense the energy through the Zoom windows and the chat. So I'm Christine Dellendorf, and as was said, and I am a family physician and health services researcher. And the program that Whitney and I work with is the Person-Centered Reproductive Health Program, and I'm the director of that. And we really focused on ensuring that people's own needs, values, and preferences are centered in reproductive health and reproductive health care with a attention to and guided by the reality of the way that oppression influences people's reproductive experiences globally, but specifically in the United States. So that's really briefly who we are. So we know we don't have a ton of time, so I'm just going to launch into telling you a little bit about why we created this tool, and then Whitney is going to tell you about the tool itself. So it's called MyBirthControl. And if you want to next slide, Whitney. So it's the bottom line, kind of the too long, didn't read point of this is that this MyBirthControl is an online decision support tool that is designed to support people in the context of a healthcare encounter to be able to have a decision-making process that is focused on their needs, values, and preferences for what birth control method might work for them. So we're going to talk a little bit about our motivation for creating this, the tool itself, and then also the results of the study that we did, funded by PCORI, to test its impact. So for a little bit of background, we know that contraceptive counseling really is something that makes a difference for people's reproductive health and reproductive health experiences. So when I first started doing this work decades ago, I heard a lot of like, oh, counseling doesn't matter. And in fact, research since then has borne out that it is a powerful influence, for better or for worse, on people's experiences. Of their ability to choose a contraceptive method that they're able to use over time. So what methods are counseled about makes a difference in terms of whether or not somebody chooses a method and knows about their options, whether or not we found in one study, whether or not people receive counseling focused on their needs, values, and preferences actually influences their continuation of a method. And we're very clear that we do not consider continuation to be a good in and of itself, because people should be able to continue a method whenever they want to, and facilitating discontinuation and support for switching methods is a patient-centered thing. But if somebody can find the method that's the right fit for them earlier, that's also a good thing, right? And we also know that quality contraceptive care affects engagement in future healthcare, right? And that's not rocket science, and you don't need research to tell you that, but that if you have a bad experience with a reproductive healthcare provider where you feel in some way coerced and disrespected in the context of pregnancy prevention, you're going to be less likely to go to them when you experience trouble achieving pregnancy, or when you're having a miscarriage, or whatever the needs might be. And we also know that, that there's a gap in the quality of contraceptive counseling. So when you look at what different aspects of quality in contraceptive care, counseling is often ranks the lowest among all of the aspects of contraceptive care. I think that's true in healthcare in general. It's not something that we prioritize in the healthcare system, getting some nods there. And we also have actually contributed to developing a measure of person-centered contraceptive counseling that is actually now included in national surveys by the National Center for Health Statistics. And in that study, in that survey, it actually found that only 50% of people nationwide actually report high quality person-centered counseling. So there's a big need and a big gap here. Okay, now next slide, Whitney, thank you. And then I don't know if any of you know this, but there's also in the past 2 decades been this real move towards promotion of specific methods, long-acting reversible contraceptive methods, IUDs and implants specifically. And these are methods that go in the arm or in the uterus and are provider inserted and usually provider removed as well. And they are highly effective at preventing pregnancy, but they also have, changes in menstruation that some people like and some people don't. Some people like that they don't have to think about it. Some people don't like that they don't have to think about it. But because of their high effectiveness at preventing pregnancy, our field in what we call family planning, which I don't love that term, but it was very focused in the past 2 decades on these methods, that these methods were the best methods and people should choose them. And if people didn't choose them, it meant we weren't counseling them often or more directively enough to choose these methods. And this is where this concept of LARC first counseling came out of, if you ever heard that, where it's that you talk about LARC, long-acting reversible contraception, IUDs or implants, early and often to kind of nudge people to choosing these methods. So it was a very directive promotion approach to counseling. Next slide. So bottom line, this is not good. This is not respectful of patient autonomy. It is not focused on patients' needs, values, and preferences. And it had produced a lot of negative care experiences. And there are studies that have documented this. This is from a study in South Carolina of an IUD initiative, where a qualitative study where people were interviewed. And this person said, they keep promoting these long-term methods. It's like they're getting a commission. I always wondered that. They were really, really trying to push this product. It was like they were selling me. And no, I didn't want to try it. So not only was this person feeling that their needs and values and preferences weren't being honored, but they were also having reactance and feeling negatively towards the care experience. Next slide. So it's not patient-centered or equitable. Bottom line, I could give a whole hour-long presentation on this, but I think you all don't need it. Providers need to hear it, the hour-long version. But it's because we are not focusing on what people want. So we shouldn't be doing directive counseling. We should be doing decision support, where we support people to think about what methods are the best for them, given what they care about and what's important to them. And I also want to mention that directive counseling is also an issue with respect to health equity, because we know that there's a long history, as I already referenced, of reproductive oppression in the United States. And specifically, this has been enacted through the healthcare system, where particularly patients of color are more likely to receive directive and problematic counseling. And so then when you layer on the top this like promotion of IUDs and implants, there's going to be that's just going to exacerbate these inequities in care experience by race, ethnicity, ability status, sexual orientation, gender, etc. So this was our motivation for creating this decision support tool as a way to support patients to be able to identify their needs, values, and preferences and engage with providers, and also nudge providers to engage with patients about what patients care about, as opposed to their suppositions of what patients should care about. Next slide. Great. So Whitney, should I hand off to you here?
Yeah.
Is that right?
Yeah.
Great. Thank you all.
Hi all, Whitney Wilson. I have been on Christine's team, just by way of introduction briefly. I've been on Christine's team almost 10 years and joined the team right as this study was wrapping up. The data collection for this study happened between 2014 and 2016. I joined around 2015. And so I've been a part of the team working on dissemination of this tool and also adaptation of it to the postpartum context, and some other tool development on our team. So that's a little introduction. I'm a project director on Christine's team. Before we dive into the results of the study, I did want to just quickly take you all through sort of like the structure of the tool and a little background on it, so you have that as we dive into sort of the results. Has the team looked at the tool in advance? Yes. Okay, great. Cool. So this might be familiar, so I'll try to go quickly. So we have lots of time for discussion. But as you know, so it's a contraceptive decision support tool designed to support people in selecting the best contraceptive method for them. It was designed by Christine through a very stakeholder engaged process, systematic development process, where we met with our own patient and provider stakeholder groups, much like this group. They advised on the content, the language, the aesthetics of the tool, and we incorporated their feedback into the final version of the tool, and also went back to them when the study was over to talk about some of the results of the study and some feedback we had gotten and make some updates to it as well. So it's grounded in research on what people want during their birth control counseling and sort of the best practices for design of a tool like this. The tool itself is meant to be used by patients before a clinical visit, and it consists of basic educational information about each contraceptive method and elicits patient preferences for contraception, meaning what's important to them, and then helps patients understand how these preferences relate to their options and communicate that to providers to support them in decision making. So today we're going to talk a little bit more about the structure of the tool and how it's structured to do that, support people in their decision making, and the results of the study to understand how its impact on the experience of counseling and that decision making process. So first, in terms of structure, the tool takes the patient through a brief educational modules that review both aspects of birth control that are important to people, such as how effective methods are at preventing pregnancy, how you use them, how often you have to remember them, and side effects of each method, as you probably saw by looking at the tool. There's also a feature at the bottom of every page for users to enter their questions they have for their provider. After the user goes through the educational components of the tool, they move on to a preference elicitation exercise like a survey, where they're asked questions about their preferences, such as how often they would like to use a method and how they feel about certain side effects. Then there's a brief health history section that evaluates eligibility for certain methods. And based on the user's preferences and their medical eligibility, the tool generates a list of recommendations. And those recommendations can help users choose the methods they'd like to talk about with their providers more. And these recommendations are divided into separate lists based on sort of like the domain area, or like the area, how you use it, how often you have to remember it, and side effect impacts, sort of based on users' preferences. And from those recommendations, patients can choose what methods they want to talk to more with their provider. There's also a cool feature where you can like compare methods. If you're looking, got some nods. Excellent. Glad you noted that too. So, and then the final screen is the user's birth control profile. And this summarizes the contraceptive preferences of the user and the methods they're interested in discussing and any questions they have. And this page can be printed out and brought into contraceptive counseling. Or you can bring it on in your phone and show your provider, that kind of thing. We have different ways of implementing the tool. And yeah, having received this information and shared it with providers allows a patient and a provider to sort of like use their dedicated time for counseling in a more focused way on the methods they're interested in. Or I'm not going to get into this, but like where a preference might contradict or be in conflict with a medical condition or a contraindication for use, and you really talk about like your preference, how these preferences and medical eligibility criteria like may or may not match up. So it sort of illuminates those areas for more deeper discussion in an efficient way for the patient and provider. Yeah, so the tool was structured in this way based on the thinking that patients can only select the method that is most likely to optimize what's important to them if they, one, have clarified what they value the most, and two, have the information necessary to match those methods to the method options. Values to the method options they have. So our tool directly addresses both of those requirements by providing people with comprehensive information about their method options, followed by this values elicitation or clarification exercise. So then how is it used in clinic? And it can be used outside of clinic as well, but we're sort of focused on the clinical context here. So the tool is intended to be used before contraceptive counseling by a patient. The individual interacts with that information and identifies their preferences. Then the provider reviews the birth control profile, and through this review comes to understand what's important to the patient, what methods they're interested in talking about, and any questions or concerns they might have. And then the patient and provider engage in shared decision making, each bringing their own expertise to this decision making process and discussion, resulting in quality contraceptive decision making. So the study of this tool, any questions about the tool briefly, or we can hold till the end too, but I'm curious.
I have a quick question.
Yeah.
Just so I can like situate this in the context of its use as you're describing it more, can you just briefly tell us how clinicians are interacting with this?
Yeah. So how clinicians interact with it, I'll focus on sort of this context of the study. Is that helpful?
Yeah. Just so I can like parallel path how.
Yeah. So for the study, the birth control profile was printed out for providers, and they were given a chance to review prior to the patient coming in for their contraceptive counseling.
Awesome. Okay. Thank you.
And that's generally the idea as well. But we also envision a world where like patients use this on their phones and they bring it into their provider and share the profile with them then and said like, I use this tool and here are my preferences, and can we engage around this? So the provider may not have a chance to review in advance per se.
Did you collect data on which way patients shared this with their doctor? They print it out or they brought it in?
So for the study, there was a printout that providers engaged with, as facilitated by sort of study staff.
Perfect. Okay, thanks. That helps a lot.
Yeah. All right, I'll share a little bit of that study. We can keep chatting. So in order to evaluate how the tool influenced counseling, we conducted a cluster randomized trial between 2014 and 2016. We had 749 patients participate in the study across 4 clinical sites in the San Francisco Bay Area. And they were assigned to use the tool before their visit or receive care as usual. And care as usual is what we call the control in this trial. The patients who volunteered to be in the study were seen by participating providers at each site who had previously been randomized, meaning they had been randomly selected to either be a tool provider or a control provider, where they were just providing care as usual and their patients were not seeing the tool. And we had 28 providers participating in the study. We surveyed patient participants at baseline, right before and after their visits, and then again at 4 and 7 months post-enrollment to assess their experience of counseling and continuation of their chosen birth control method, among the outcomes that we'll discuss in a minute. We also collected provider level data. The 28 providers took a survey before and after the intervention was implemented at their site to understand sort of their experience with the tool and how it impacted clinic, et cetera. And we also audio recorded 1 to 3 contraceptive counseling visits per provider who was in the tool category, meaning their patients did see the tool, to understand sort of how it was implemented and what impact it had on their conversations. Our primary outcome, meaning the outcome that we expected to change as a result of using the tool and were interested in at the beginning, the caveat, was continuation of patient's chosen method at 7 months, I believe, post contraceptive counseling. Thank you, Christine. I did not indicate that in my notes. Oh no, it's on the slide. It just wasn't in my notes. However, in the 2 years of data collection, we came to really feel that the most patient-centered and therefore the most valuable outcome of this project was patient satisfaction with their contraceptive counseling. And I'll share a little bit about how we defined that in a minute when I share the results of the study. And there were a number of other outcomes, and the ones that we found most interesting are patient decision conflict in contraceptive choice, patient attitudes and knowledge of contraceptive options and features, patient satisfaction with their chosen method. So who participated in our study? Almost half of our participants were under the age of 24, which I thought might be of interest to this group. They were largely Hispanic, Latina, or white, English speaking, and had not given birth before. So we found no difference in method continuation, which I think the key takeaways Courtney had shared in advance of the meeting did highlight in the tool and control arms. But as we know, and Christine mentioned this, there are a lot of reasons why patients may decide to discontinue their method, even if they were totally satisfied with their choice and contraceptive counseling at the time they chose it. So the tool did find, however, a positive impact on patient experience of contraceptive counseling and decision-making. And this is really important given the personal nature of contraceptive decision-making. Patients who used the tool before their contraceptive care visit were more likely to report having experienced patient-centered counseling, which was measured by the interpersonal quality of family planning care scale. And this is a 4-question measure that Christine mentioned earlier that asks patients to rate their provider on how well they respected them as a person, let them say what mattered to them about their birth control method, took their preferences about birth control seriously, and gave them enough information to make the best decision about their contraceptive method. We also looked to additional results or findings, additional results included findings that participants who used the tool indicated complete satisfaction with the information they received about side effects. A greater proportion of tool users reported making an informed contraceptive choice. And they had accurate knowledge scores across a number of different domains, including about LARC methods or side effects. And I just we pulled a couple of quotes in from patients. In the words of patients who used the tool, they said, "I was able to ask better questions and be more confident in that not just knowing," I was able to ask better questions, be more confident in that, not just going into it like being like, whatever, I don't know. Another patient said, "It made my visit go much faster. I had really direct questions. It made it really easy for the clinician because I was already informed of all the stuff." And in the words of our provider, the tool allowed me to be more targeted in my counseling as opposed to starting from scratch. I had a foundation to focus on folks' preferences and what they wanted to talk about instead of what providers think clients should know. Oh, and that brings me to the end, actually. Great. So that's a high-level summary of our results. We're looking forward to discussing this further with you.